I'm Jackie Camilleri. I'm the CEO of Golden Care Home. Golden Care Home is a 235-bedded care home in Gargur in Malta. I actually touched healthcare way back in 1993, where I was part of a group, a private group, and it was the first time that in Malta we're talking about setting up a private hospital. Actually, the hospital opened in '96 when healthcare was private healthcare was very much in its infancy. And we could see that many Maltese could not even afford private healthcare. Your question is really focused on long-term care, but I'm giving this background because there is a similarity between the two, affordability. If you really had to look at and ask yourself a rhetorical question, who is the main funder in Malta? First of all, it's a national insurance-based healthcare system, and the primary client, the primary funder, is government. And I've been involved in healthcare, that's why I gave my background, early days, '94. And I didn't stop being involved in healthcare. From the private healthcare sector, I actually moved to the Foundation for Medical Services, which was, and still is, part of the ministry, actually an annex, an ancillary to the Ministry for Healthcare. I went up the ranks over the years as a director and Director General Finance at the Ministry for Health, at the time where the Ministry for Health was also known as MHEC, which is Ministry for Health, Elderly and Community Care. And again, the budget, I've seen the budget grown over the years. I left the ministry in 2014, but the budget had increased then from 300 million to close to 500 million. And it didn't stop increasing. I mean, even in the last couple of years, even the last budget, funding in healthcare and in social care has always been very much at the forefront. So the answer to your question is the main funder is definitely government. However, given the increase in demand in LTC, as an acronym, stands for long-term care, and with the change in demographics and the increase in aging population, although Malta is a small island and family support has always been very big in Malta. So we remember days, I mean, my father talks about his family being a family of 10, having family support from grandmothers to uncles and aunties. That kind of has decreased a lot over the years. I mean, talk about my own daughter who studies abroad, and we've seen students leaving the country, studying, families becoming smaller, having less children. So obviously the demand has kept on increasing, people becoming older, and government having to fund more. However, this brought with it an interest from private entrepreneurs. Mostly, I'm an accountant by profession, and I work a lot in the industry. Actually two sectors I work in. One is hospitality, besides healthcare, and the other one is property. And I've seen investors taking a particular interest. Why? Because obviously there's demand. So we've seen investors coming from the property market, in particular property development, acquiring lands or changing already property that they own into care homes. And we've seen care homes mushrooming. I would say since 2015, 2016, we've seen a massive increase in private investors investing in private care homes to be able to meet this demand. With long-term care increasing and families shrinking, obviously, when one finds himself in a bit of a rut, if I might say, having to cope with your daily living, your family, your own family, and you have an elderly father, an elderly mother, elderly parents, if you like, that are actually in need of long-term care, no longer sustainable at home, what do you need? What do you do? You seek help. And with the model that we have, they tend to seek help through government for two main reasons, really. Private healthcare, like anywhere else in the world, is expensive, promulgated by the fact even further that long-term care, there's the uncertainty. Nobody knows how long one is going to live. Even if you are diagnosed with a very bad prognosis, unfortunately challenging prognosis of dementia, it doesn't mean you're going to die. On the contrary, you might have an early onset of dementia, you still need long-term care support, or Parkinson's or Alzheimer's, but it can also be Huntington's. It can be all sorts of high dependency, obviously, prognosis, where the family can no longer support. And even if they try to support, they don't have the means, or they don't have the knowledge, even the clinical knowledge, or the right equipment, which gives obviously the right ambience, to be able to support that individual within the family. So obviously they tend to seek help. And you seek help privately, and I've seen it time and time again, even in the last couple of years. Privately, once you send a quote, very few and far between would tend to tell you, yes, this is affordable, or else if they can afford it, they will afford it for a while, and then they would still seek help from the main funder, which still is, and in my opinion, remains government. We don't have an entitlement or a means testing system in healthcare. Why should Malta be any different? It's a smaller island, but the same challenges. Again, change in demographics, there's demand. As a result, you need to meet that demand with supply. So, given what I've said earlier, care homes mushrooming, everybody is seeking or trying to fight for the same resource, which is actually the carer, senior carer, nursing assistant, and staff nurses. Amongst them, given that a lot of people are relying on government service provision, government is also a contender in this equation, so he's also fighting with the private sector for the same resource. So what happened over these years, I would say 6 years, 7 years, mainly, we tend to look away, offshore, for the main resource in healthcare is obviously, I'm taking that as a granted, is the HR resource, the skilled, experienced, qualified professional resource. Because irrespective of the facility, irrespective of the design, if you don't have the right resource, you can't provide the level of care, quality care that one fights for, to make sure, obviously, that you retain that service. As a result, we tend to get a lot of third country nationals in Malta. Primarily, I, for one, work a lot with Filipinos, Indians, but I've seen also people coming from Pakistan, even from Nepal. But mainly Filipinos and Indians seem to be very, very high on our agenda. Mainly, we seek Filipinos and Indians, including government. If you go to Mater Dei, general acute, not necessarily St. Vincent de Paul residents, you will see a lot of Indians and a lot of Filipinos, because there's a shortage. I have to say, I actually find no objection in recruiting third country nationals, because they're highly qualified. We talk about MVQ levels, MQRIC levels, and more often than not, these people are actually, they either have a diploma or are nurses, even nurses and midwives at times. So you're looking at MQRIC levels 4 minimum, mostly 5s and even 6. My heart goes out to them. In fact, to make it a point, even at Golden Care, the care home I manage at the moment, to leave room for promotion, because usually the showstopper is money. Because let's be frank, these people look for jobs elsewhere, leave their country, to make sure they better their financial position and be able to support their families. So when they come, because of it's legislation, even though they might be a nurse in their own countries, we can't employ them as nurses. So we employ them as carers. With an MQRIC 5, even MQRIC 6s, we employ them as carers. Once we get to know each other and you see their competence and obviously their commitment and loyalty, and I have to say most of them are very, very highly committed and they work very long hours. And as you said, pay is as it is. Unfortunately, it's a profession, because it is a profession that doesn't pay very, very well. But we give them the opportunity, and even at Golden Care, we support their studies. And most of them, they do the nursing adaptation in time. And once they get the warrant, we promote them to a nurse. Prior to that, even if they pass exam, because I have a couple at the moment, they pass the exam, but they still waiting for the warrant, we still promote them to a nursing assistant. In terms of recruitment, people do it differently. There are those who, from a business perspective, say, I need third country nationals, let's put this delegation together, maybe an HR director, maybe the owner himself, or someone else, maybe a clinical lead, and we go to them and do interviews there. I know that that model exists. There are others who work through agents. I do it completely different. I know the sector, I've been there, done it, seen it, and I don't particularly like recruiting people who are still abroad, which is more challenging, because I'm a firm believer that one of the attributes, which is a must-have, is also communication. So you need to have the MQRIC 5, you need to have the right qualifications, you have to have the compassion, you have to be professional, the right qualifications, training and experience, but most importantly is also the language. So at least if you can't speak Maltese, I definitely would want candidates that would, and the culture, would have lived here for a number of years, ideally not less than a year, ideally would have worked somewhere else. I'm not going to poach, but I very often retain the standard within the care home I'm actually managing, and people, amazingly enough, actually reach out to you. And here we employ 164 people, 100 of whom are in care. And every day I receive CVs still We have another project in the making, and I'm sure it will be no mean feat, challenging, but we'll get there. And they will be employing another 225 people soon. Obviously, I can't talk about COVID from a ministry perspective because I'm only one service provider in a care home in the community. But I have only words of praise. I have to say it was very, very professionally led by the Ministry for Health and the Ministry for Family and Social Solidarity. I don't know the exact name of the ministry, but both ministries handled it extremely well. We had clear protocols, clear guidelines, and they were nimble enough. And I think the most important is actually the word nimble, because the situation kept on changing from day to day, from second to second, if I dare say. And the protocol escalated when it needed to escalate. I remember the worst months were actually November and December last year, where it was really at its height, its prime, with Christmas coming. But by first week of December, here in this care home, I actually, like many other care homes, we did have COVID cases, and they were mainly in November, towards the last part of the wave. But by first week of December, we were COVID-free. But we had very clear guidelines, good communication, and the plus side to COVID is that it made us work as a team. So we had the regulator, the Social Care Standards Authority, working with primary healthcare, even primary healthcare, visiting consultants, visiting doctors, working with our own clinical leads, matron, staff nurses, with us as management, setting up isolation units. But it was all prepped, so we started early on. We didn't waste time. So not only was government working within Mater Dei, within the community setting hubs, but there was also the inoculation program. And again, this led me to procurement. So even from the ministry, they procured inoculation vaccines through central procurement supplies. So the drill was done. We really worked well. So in terms of funding, if I had to go back, and I have to give this as a bit of background, when I myself was a Director General at the Ministry for Health, as a Director of Finance, it was always a challenge, and things didn't get any better. Why? Because you have the client who over the years has become more aware, as a result more demanding. On the other hand, the main funder is government. So I remember in the days of the budget, prior budget, run up to the budget, which would start in August, which would lead up to October, health was always at the forefront, fighting for more, not to waste, but to increase the services, or to up the services, or to increase the pharmaceutical formulary list, pharmacy of your choice, which came into existence in 2007. Things did not change. On the contrary, long-term care has boomed. Aging has boomed. I spoke very briefly about it earlier in a little conversation, but I hate calling them social cases, but more often than not, we used to look at statistics even through Mater Dei, and year after year, you would see clients coming in through A&E or through an emergency, triage very quickly, finding themselves occupying a bed in an acute setting, which, as we all know, is a very expensive bed. Each overnight stay is expensive, and it's not only expensive, but it's also blocking the provision of acute care. With that in mind, obviously, the acute management team would push as much as possible with energy, obviously with dedication and passion, to move that client out of the system into LTC. And as a result, we've seen over the years not only funding increasing for one demand for more funding from acute, but also from long-term care. So we've seen the budgets increasing at St. Vincent de Paul residence, which is, I wouldn't call it a care home, but more of a hospital because it's a residence, with the numbers increasing, with the services increasing, with new wards opening up at St. Vincent de Paul, but also, as I said earlier, with private investors seeing this as a niche, as an opportunity for investment, and with care homes in the community increasing. Having said that, the challenge didn't become any smaller, not at all. Because as a result, the client has become more demanding. The client is now choosing. The client is now aware of the type of service or services, if you like, that he's after or that his relative deserves. Really and truly, I don't have a magic wand. And I don't think government has it either. And I don't think it's going to go away. For Middle East and Northern Africa countries, as I said, I don't think the problem is going to go away. As tough as it may seem, and obviously probably politically not very popular, but I'm going to talk to you with my financial hat on. If something is unsustainable, and we call it it's bleeding, there's hemorrhage, what do? You stop the hemorrhage. So I think it's going to reach a point where, obviously we didn't mention it, but I'm going to mention it. There's a lot already has been done with respect to pillar pension systems, people able to work longer. Even with the last budget, we've seen rebates for carers, increase in home help services, and somehow it's never enough because this is going to keep on increasing. We've seen the baby boomers, more demand. So if I had to look at it from a financial perspective, I think there are two things that need to be done. Means testing, as tough as it may be, and it's not easy. But if you look at Malta, it's unaffordable. If you look at the rates without actually being specific, and the fact that towards end of life, there's uncertainty, you might get a bad prognosis, bad diagnosis, but you never know how long you're going to live. And the fact that you're surrounded by relatives, it's not going to sound nice, but I'm still going to say it. People start thinking of inheritance and start, particularly if there are more than one daughter, siblings, it starts becoming a bit edgy. The situation starts becoming very edgy. Particularly if you're the service provider and you know that the prices are what they are, and obviously with the expertise, the level of service we have to provide, care is expensive. And a lot of people in Malta cannot afford it. If you look at the average pay that one earns and compare it to the daily rate, and let's call a spade a spade. People look for institutional care when one requires medium, because we didn't talk about this, medium to high dependency care, and that tends to push the price even higher. And then there would be extras, and the price keeps on piling up. So I don't think the situation from a client perspective is going to become affordable. On the contrary, on the other hand, government can't keep on giving everything out for free. So, as simplistic as it may sound, and obviously it's not, I think means tested is the way forward. From an investment perspective, given that supply has increased and that more investors have invested in care homes, I think it has to be fair play. And the only way to retain the service, if I had to give advice to government as you put it, I think one has to create some system of measurement, to put it simply, so that we understand each other. And like in UK, we talk about star rated, and not only in UK, in EU countries, we talk about promoting or rewarding people who invested, which is the star rating system. I would recommend a star rating system, which in Malta is actually used for hotels. If one talks about a 5-star hotel and compare it to a 3-star B&B, one would immediately know that the service is different, the price is different. So I would recommend to government that it would star rate homes in the same manner as an analogy, hotels are star rated. So then when we look at the funding, because as we speak, because I didn't delve into it a bit deeper, if I have the time I would delve into it a bit deeper, we have a system which is funded by government. So although the investor actually invests in a care home, government pays but takes part of the pension, a percentage of the pension of the client. But still, the biggest bulk is actually coming from government. So at least the investor who would have invested more, I think, deserves to be paid more.